Hi friends, welcome to nerdsbazaar.com. Today we will discuss about peptic ulcer. So in this chapter we will discuss what is peptic ulcer, different type of peptic ulcer, then the possible management, mainly the surgical management. So after watching this video you will be able to learn various things about peptic ulcer, and don't forget to see to the last of this video so that you will learn more about the surgical management of peptic ulcer. Not only about the surgical management, regarding the etiology or causes of peptic ulcer, why this peptic ulcer is happening. So please watch it, and if you like this video, please like it and subscribe. Let's continue. Peptic ulcer is ulceration in the mucosal wall of the stomach, in the pylorus, in the duodenum, or in the esophagus. So mainly peptic ulcer means it may be ulceration in the stomach and pylorus. Pylorus means the last part of the stomach is called pylorus. So maybe in the pylorus, and sometime in the duodenum, and sometime in the esophagus. So together we can say peptic ulcer. The main cause for peptic ulcer is H. pylori infection. Before it was thought that because of some other stress, some other problems, but now it was identified that H. pylori infection is the main reason. See, I told that it may be in the stomach, or it may be in the duodenum, this ulcer. So we can divide this duodenal ulcer or gastric ulcer. Let's see what is the difference between duodenal ulcer and gastric ulcer. Both are part of peptic ulcer. So if you see duodenal ulcer, 80% of the peptic ulcers are duodenal. Okay, so 80% of peptic ulcer are duodenal. Only 15% of the peptic ulcer are gastric. And when it comes to signs, symptoms and other clinical findings, you can see this duodenal ulcer is happening because of hypersecretion of stomach acid. Hypersecretion. Because of hypersecretion, you are getting this duodenal ulcer. But in gastric ulcer, it may be hyposecretion of stomach acid, maybe because of hyposecretion of stomach acid. And in duodenal ulcer, patient may get weight gain, but in gastric ulcer, weight loss is occurring. The next point is very important. In duodenal ulcer, pain occurs 2 to 3 hours after a meal, and sometime between 1 to 2 a.m. in the midnight, 1 to 2 a.m. patient may wake up because of pain. So pain occurs 2 to 3 hours after a meal. But in gastric ulcer, pain occurs half to 1 hour after a meal. So if a patient is getting pain after taking meal, suddenly after taking meal, it is gastric ulcer. And if the patient is getting pain after 2 to 3 hours, or sometime patient is waking up in midnight, it is duodenal ulcer. Then ingestion of food relieves pain. So when patient take food, when patient is having pain, and if the patient is taking any food and the pain is relieved, it means it is duodenal ulcer. But in gastric ulcer, pain may be relieved by vomiting. Ingestion of food or intake of food does not help, sometimes increase pain. Okay, so in gastric, if you take food also, pain will not go, sometimes it will increase, but after vomiting patient may get relief. But in duodenal ulcer, after taking food, patient may get relief. Then vomiting is uncommon, but in the case of gastric ulcer, vomiting is common. Then melena are more common than hematemesis. So in duodenal ulcer, patient will have melena. Hematemesis means vomiting of blood is less, but gastric ulcer, hematemesis is more than melena. You will not see melena in gastric ulcer, you can see more hematemesis. And risk factors: H. pylori infection, alcohol, smoking, cirrhosis, then stress. In here the risk factors are same: H. pylori, alcohol, smoking, use of NSAID, stress. Next, come to assessment: barium study, endoscopy, then you can do cultural study for H. pylori. Then medical management, you can give antibiotics, then proton pump inhibitors and bismuth salt. All these bismuth salt and proton pump inhibitor, this will help to reduce the acid secretion, because when there is more acid secretion, it will cause more ulcer and more problem. Then the next one is surgical management. This is very important. Surgical management, first one is vagotomy. Here what we are doing, we are surgically removing the vagus nerve. Surgically what we will do, we will remove the vagus nerve. When vagus nerve is removed, then it will decrease gastric acid by diminishing cholinergic stimulation to the parietal cells, making them less responsive to gastric. Together we can say after removing the vagus nerve, the secretion, because the cells will not stimulate, so there will not be more gastric acid secretion, so you will get relief from gastric ulcer. Then next is pyloroplasty. It is a surgical procedure in which a longitudinal incision is made, and then so what will happen, it will relax or enlarge the outlet. Here we will enlarge the outlet by making an incision. So what will happen, this area will enlarge, so whatever the food is coming in the stomach here, it will easily go to here. There will not be any sphincter or control, so food which is coming here will easily go into the duodenum, so food will not stay more time in the stomach. So if food will not stay more time here, then it will not produce that much secretion or more secretion, so it will relieve ulcer. If food stay more time here, what will happen, more secretions will come, then it will cause more problem. So here what is happening, because you do a surgery here, you put a incision and you made enlargement of this area, so what is happening, food will go suddenly to duodenum, so food will not stay here, so it will not affect or it will not make more secretions. Then Billroth surgery, this is very important, Billroth surgery, but it is a simple one. The name is Billroth surgery. There are two type of surgery, Billroth 1 and Billroth 2. Removal of lower portion of the antrum of the stomach as well as small portion of the duodenum and the pylorus. So first what we will do, we will remove the small portion of the antrum. Antrum pylorus means the last part. So see, if this is a stomach, you will remove the last part of the stomach, that is antrum and pylorus. Last part of the stomach is antrum and pylorus. You will cut and remove it. And also you will remove duodenum, and the remaining part will anastomose to the duodenum. See here what is we are doing, you removed the part of stomach, then you removed a small part of duodenum, then you are attaching the remaining part of the stomach to the duodenum. So this is called Billroth 1. If the same thing what you are doing here means, you removed a part of stomach, you removed a part of pylorus. Pylorus means a part of stomach only. So you removed a part of stomach, then pylorus, then you removed a part of duodenum. The remaining part you are attached to the jejunum. Here you are attaching to the jejunum. So that is Billroth 2. So you remove a part of stomach and attaching to the duodenum means it is Billroth 1. If you are removing part of stomach and you are attaching to the jejunum means it is Billroth 2. So there are two surgery. Okay, this is very important. If you are attaching to duodenum, it is Billroth 1. If you are attaching to the jejunum, it is Billroth 2. Thank you for watching this video. Please subscribe our video. For online nursing coaching, contact www.nursebasa.com or WhatsApp me on 00971 522069493.